Good afternoon, everyone. I'm Anjali Khadka, and my student ID is 22145823. Today, I'll be presenting a case study on Mrs. Teresita Manalo, who was diagnosed with an embolic stroke. In this presentation, I'll discuss the pathophysiology of embolic stroke, provide an A to E assessment of her vital signs, outline 4 key nursing interventions, and explain 3 medication considerations relevant to her case study. Now, I would like to introduce everyone to Mrs. Teresita Manalo, who is a 68-year-old female. As we can see on this slide, Mrs. Manalo's case highlights the complex interaction between cardiac and neurological systems, emphasizing the importance of rapid assessment and evidence-based care. Now, I would like to ask everyone a question. Do you know what happens when a clot travels from heart to our brain? Where our understanding of pathophysiology begins. Here we can see a visual representation of how blood clot is formed in the left atrium and how it affects the brain and leads to embolic stroke. When the thrombus is formed in the left atrium during the atrial fibrillation, which then enters the blood streams and lodges in the cerebral artery, which stops the blood flow, resulting in an embolic stroke. It results in an ischemia-induced neuronal energy failure, ionic homeostatics, excitotoxicity, oxidative stress, and cytotoxic edema, and cellular death in the infarct center. Now, I would like to ask everyone, what is the consequences of this chain? Then the loss of oxygen happens, so like in the case of Mrs. Manalo, which means the loss of function. That's why understanding this mechanism is critical in responding quickly and appropriately in the stroke management. I would like to do the A to E assessment, which provides a systematic and prioritized framework to detect and manage deterioration in acute stroke patients like Mrs. Manalo. Now, I would like to talk about airway. We can have a look at this diagram and we can see how the airway is obstructed, involving speech and swallowing difficulty. In Mrs. Manalo's case, her airway is patent and she can still follow the commands and verbalize, though with a slurred speech and a declining level of consciousness. These findings suggest oropharyngeal muscle weakness, impaired cranial nerve coordination consistent with embolic stroke's neurological impact. Thus, the stroke may have affected her motor control of the tongue and the pharynx. She is at high risk of dysphagia and aspiration. Now, I want to ask, do you know what could happen if the airway risk is not assessed in time? It could lead to aspiration pneumonia and secondary hypoxia. The image illustrates oxygen exchange and respiratory muscle involvement. Mrs. Manalo's respiratory rate is 26 breaths per minute and her oxygen saturation is 95% on 6 liter via Hudson mask, indicating increased respiratory effort and early hypoxia. In embolic stroke, this may occur due to weakness of respiratory muscles or brainstem involvement, reducing effective ventilation. As per the Stroke Foundation 2023 recommends maintaining an oxygen saturation of greater equals to 95% to prevent cerebral hypoxia. If the oxygen saturation falls, how might that affect the ischemic brain? Reduced perfusion could worsen the infarct area. Therefore, continued oxygen therapy and monitoring respiratory patterns are crucial for maintaining adequate cerebral oxygenation in a patient like Mrs. Manalo, which is happening right now in her case. Now, let's have a look at Mrs. Manalo's circulatory assessment. Her heart rate is 132 beats per minute, which means she is atrial fibrillation right now, and her blood pressure is 170 over 95 mmHg. This image reflects sympathetic nervous system activation and the body's autoregulatory attempt to maintain the perfusion to the ischemic penumbra. Because atrial fibrillation causes turbulent blood flow, thrombi can form and embolize to the brain. Her peripheral coolness and pedal edema indicate reduced cardiac efficiency and venous congestion. Ask everyone in stroke, why is maintaining stable circulation so vital? Because every drop in perfusion pressure can mean further neuronal loss. That's why it is so important to maintain the circulation in embolic patients. Let's talk about the next part, which is disability. As we can see in this image, the right middle cerebral artery region controls motor and sensory functions of the left face and limbs. Mrs. Manalo GCS is 12 out of 15 with the left hemiparesis, facial droop, and slurred speech. All of them are pointing to right middle cerebral artery infection. When blood flow in the middle cerebral artery is reduced, neuronal energy failure and cytotoxic edema occur, leading to motor deficits and speech impairment. In In a context like Mrs. Manalo, progressive neurological deterioration demanding immediate review, recognizing these signs early enables us to act before irreversible damage occurs, which happened in Mrs. Manalo's case because they found her with lost GCS. Now, let's go to the next part, which is exposure. This slide shows peripheral circulation and skin assessment findings. Mrs. Manalo is afebrile, but she has pedal edema and peripheral coolness, reflecting reduced venous return due to atrial fibrillation and limited mobility. This imbalance between central and peripheral circulation increases her risk of pressure injury, deep vein thrombolysis, and infection. High exposure assessment is very important in stroke patients because it allows us to detect complications before they escalate. If the risks are not addressed, what might happen to the recovery trajectory? It leads to reduced mobility, infection, and delayed healing. That's why full body assessment and pressure area care are key to preventing secondary complications in stroke patients like Mrs. Manalo. The first thing I would like to do for Mrs. Manalo is to activate the stroke team, arrange a stat non-contrast CT to determine her eligibility for reperfusion therapy. Because restoring cerebral blood flow early preserves the penumbral tissue and improves outcome. You know what happens if we delay this step? Ongoing ischemia leads to neuronal death and poor recovery. While waiting for the stroke team and a non-stat CT, I would like to monitor her vital signs, which ensure she stays safe within the safe pre-TPA limits. If hypotension develops, fluids or vasopressor should be used to maintain perfusion and further ischemic injury. This slide also highlights the need for comprehensive assessment, skin check, limb exercise, and pressure care to prevent complications like pressure injury, deep vein thrombolysis, and infection. This holistic approach not only supports circulation but also preserves skin integrity and enhances recovery. Airway protection and dysphagia management. Analgesius was dropping, her speech became slurred, airway protection became a top priority. I would like to position her in a semi or high Fowler's position to reduce the risk of aspiration and atelectasis, and keeping her nil by mouth until a swallow screen is completed to ensure her airway is patent. Continue her at 6-liter oxygen via Hudson mask, maintaining oxygen saturation of greater equals to 94%, consistent with Stroke Foundation 2023 guidelines. Why is maintaining oxygen saturation so important? Because hypoxia and aspiration are the two main causes of morbidity after stroke. Think about it. If aspiration occurs, how would that affect the already ischemic brain? It could cause further hypoxia, worsening neurological injury. Why speech pathology and physiotherapy referrals are critical to support airway clearance and breathing exercise. Even I would like to do oral hygiene, which will reduce the infection risk, supporting her neurological recovery. Nursing intervention I would like to do for Mrs. Manalo is cardiac monitoring. Slide shows and reading of atrial fibrillation and a blood pressure monitor, both vital in stroke management. Mrs. Manalo's is tachycardia at 132 breaths per minute and high blood pressure of 170 over 95 mmHg, which signal toward cardiac workload and risk of embolism. Continuous ECG telemetry and APTT monitoring guide safe anticoagulant therapy and detect rhythm abnormalities early. If I would like to continue the ECG telemetry and APT monitoring to guide the safe anticoagulant therapy and detect rhythm abnormalities early. If her BP exceeds by 220 over 120 mmHg, gradual reduction is advised, but dropping it too quickly could worsen cerebral ischemia. So I would like to maintain a balanced BP to ensure adequate cerebral perfusion without increasing bleeding risk. Might happen if we overcorrect her blood pressure too fast. We risk cutting off oxygen to the penumbra. If she has already got the pedal edema, as a nurse looking after her, I would like to avoid fluid overload while ensuring IV patency for medications and monitoring capillary refills and screen temperature to assess the perfusion. I would like to regularly check Mrs. Manalo GCS, temperature, glucose level, and limb strength, which helps me to identify early signs of deterioration in her. I would like to collaborate with multidisciplinary stroke team, physiotherapy, occupational therapy, and speech pathology, which supports the functional recovery and prevents complications. According to QPRS 2025, elevating the head of bed to the 30-degree promotes venous drainage and reduces intracranial pressure, improving cerebral circulation. Now, I want to ask my audience, why is ongoing neurological monitoring so crucial? Because subtle changes may be the first sign of reocclusion or bleeding. Timely recognition can make the difference between recovery and irreversible damage. Now, I would like to consider the three medications for Mrs. Manalo considering her medical condition. The first thing I would like to do before administering IV altiplase to Mrs. Manalo is I would like to do a non-contrast CT to confirm there is no hemorrhage and a coagulation profile. APTT, INR, platelets must be checked. IV altiplase is given as 0.9 milligrams per kg, maximum 90 milligrams, 10% as an IV bolus, and the remaining 90% via infusion over 60 minutes. When we administer the IV altiplase to Mrs. Manalo, we need to monitor the vital signs and neurological status every 15 minutes to ensure early detection of adverse effects like intercerebral hemorrhage or bleeding. Rationale. Altiplase promotes fibrinolysis, restoring blood flow and minimizing ischemic injury. By controlling blood pressure and monitoring closely, we reduce the risk of hemorrhagic transformation, supporting safe and effective reperfusion. Now, I would like to ask everyone, would you administer IV altiplase if the patient BP were on control? Absolutely not, until it is stabilized back. This slide highlights the heparin's anticoagulant mechanism, enhancing antithrombin third activity to inhibit thrombin and factor XA. Before administering, I must check baseline APTT, platelet count, and renal or hepatic function, ensuring Mrs. Manalo has no heparin allergy or heparin-induced thrombocytopenia. Heparin is infused using a control pump with APTT monitor every 6 hours until it is stable. Rationale. Heparin prevents recurrent embolic events in atrial fibrillation by suppressing clot formation, but excessive dosing risks bleeding and thrombocytopenia. Rationale. Heparin prevents recurrent embolic events in atrial fibrillation by suppressing clot formation, but excessive dosing risks bleeding and thrombocytopenia. Why do we monitor APTT so frequently? Because even small deviations can turn therapeutic anticoagulant into life-threatening bleeding. That's why. Manalo is an anticoagulant. Pantoprazole is essential for the gastroprotection against stress ulcer and GI bleeding. Before administration, I would like to check her LFTs, electrolytes, and allergy status. I would like to reconstitute the 40 milligrams vial with the 10 milligrams 0.9% NaCl then dilute with 100 ml NaCl and infused over 15 minutes or slowly over 2 minutes if needed. Rationale. Pantoprazole inhibits hydrogen ion or potassium ion ATPase in gastric parietal cells, reducing acid secretion, preventing mucosal injury. Once Mrs. Manalo can swallow safely, it can be switched to the oral administration. Why is gastric protection so important in anticoagulant patients? Because even minor bleeding can become life-threatening in patients with anticoagulant medications. Now, I would like to conclude my slide. In summary, Mrs. Teresita Manalo's case emphasizes the interconnection between cardiac dysfunction and cerebral ischemia. Through timely assessment, targeted nursing interventions, and safe medication administration, we, as a nurse, play a critical role in improving recovery outcomes. So, what do we take away from this case? That every minute counts and every action we take as a nurse saves the neurons and preserve function. Are my reference which I'm referring to. And thank you everyone for listening.